I have two esteemed colleagues to help me. I've got Anton Arvidsson to do some of the loading for the embryology part, and I've got my good friend Joaquin Blanco Sanchez, who's going to talk to us a little about the witnessing steps included in embryo transfer and some new technology that Cooper have introduced. So we're first going to do a few slides to build up the background. Then Anton and I are going to talk through one way of loading an embryo transfer catheter, and then we're going to do a demonstration on our simulator here to try to highlight some of the key points when you're doing an embryo transfer. So, do we have anything to help us in the literature which will help us describe what is a perfect embryo transfer? And although there are many guidelines from ESHRE, from ASRM, from other national bodies, they don't describe in detail, A, B, C through to Z, exactly how to do an embryo transfer. But within the guidelines, they give us some indications of those parts of the embryo transfer excuse me, that are critical and steps that we really need to take control of. We need to remain in an optimal condition to give us the best chance of success for our patients. So we can look up the guidelines. They'll tell us various factors that we need to consider, but ideally we need to set up our own protocol within our own clinic that's going to work effectively. And one of the things when we look at the literature and we look at consensus, even some of the things that we think everybody would do, we find when we ask, not everybody does. So there is consensus on some things. The bottom you can see, everybody checks the embryo transfer catheter after the transfer to see whether there are retained embryos. But on other factors, we know that it's not universal. So flushing the embryo transfer catheter is not universally adopted in clinics. And we know that's important. And during the demonstration, we'll explain why. So you can see this, among other papers, other studies, really demonstrate there is no true consensus on the best way to do an embryo transfer. So how do we know which factors are important? So we're going to talk about where we have evidence and what we believe through experience and from the literature is going to give us the best chance of success. Now, one thing that is for sure, and the literature is quite categorical about this, unequivocal, that ultrasound-guided embryo transfers are better. To a point where the British government, from the National Institute of Clinical Excellence, actually recommend that all embryo transfers are done under ultrasound guidance. Because of that, we need good ultrasound, we need good understanding of the ultrasound procedure, and we need a catheter that we can see on the ultrasound scan. So the other part that has very strong evidence to support it is the type of catheter that we use for transfer. So we need to use a soft catheter that's not going to cause any damage, do the most atraumatic transfer that we can, and ideally is extremely visible under ultrasound because that's going to help us. And the only other factor that has grade A evidence in embryo transfer is that patients don't require bed rest after the transfer. Everything in between has some evidence, but not of the highest quality. So that's where variation comes into the system. So we're going to talk today particularly about some of the embryology factors. And here's a slide that's talking about loading technique of the embryo transfer catheter. So when we've got our embryo out of the incubator, we brought it to the microscope, which we'll demonstrate in a short while. We have a number of choices about how we load the embryo transfer catheter. Whether we use a solid column of medium, right down to the bottom where we use just a column of medium. The bottom you can see, the bigger column has the embryo in, and just a little plug of media at the end. Now, when you examine the literature, all of these techniques give the same result. So it doesn't matter whether you load A, B, C, D, etc. They all give the same result. But there are some considerations within that. One of the key factors is the volume of the drop that the embryo sits in. So whichever of these techniques you use, you'll see from the diagram that the column that the embryo sits in is the same in every scenario. So volume of transfer medium is a key factor. We cannot keep increasing the volume to load. We have to have a maximum, but also we have a minimum, because if you load with too little volume, then that can lower the pregnancy rate, partly because there's a risk the embryo will stay attached to the catheter itself. So despite whichever of these techniques you use, doesn't matter, but the volume that the embryo sits in when you do the transfer does matter. And if your clinician or nurse that does the transfer likes to feel a big push on the syringe that you use, then you need to load air to make that syringe push further. You can't keep adding medium. And we'll just demonstrate one way of loading the catheter as one of these, but there are many ways to do it. So as I mentioned, you can load in different formations like this, but the volume that you load in is the critical factor. A question I'm asked a lot when I travel around the world and talk to embryologists about embryo transfer is, what embryo transfer medium should I use? And again, we have multiple choices here. We can use a bicarbonate buffered media, so the medium that we would use for culture. We can use a HEPES or a MOPS buffered media to do the transfer without a problem. Or we can use some specific embryo transfer media, those that contain hyaluronan, or now we see some that have GMCSF, a cytokine. Whichever of these transfer medium that you use, it's imperative that at the time of transfer, that medium is optimized. Very often, culture conditions are really very good in the lab. We get good quality embryos. We come to the embryo transfer dish, and it's prepared a long time in advance. And if you prepare a dish a long time in advance, you incubate it, you run a very strong risk that evaporation will take place, pH will increase, and osmolality will increase. So if you can use a bicarbonate buffered media, probably as good as it can be, but you've got to consider temperature and you've got to consider CO2 concentration. If we move to HEPES or MOPS, we don't need to consider CO2, but we do need to consider temperature. Okay? And then some of the other media, the ones that contain hyaluronan or contain GMCSF, etc., again, they need to be prepared in an optimal way. So when you put your embryo, your precious embryo at the time of transfer, it goes into an optimal condition. It hasn't drifted over time. And it's a very common mistake we see in the embryology lab. Times come and go, trends come and go. In the early days of embryo transfer, we thought that increasing the viscosity of the transfer medium would help. So adding extra protein to increase viscosity, we believed was going to help us get better results. Again, if you look at the literature, it really doesn't make any difference. So that's why we can just use standard culture media or protein-containing HEPES media. Okay? So the choice of transfer media is important. There's lots of things to consider, but whichever you choose, optimal conditions are really crucial. And we come to some new developments, and we have a stand discussion later in the week regarding GMCSF, but just to share a little bit of information with you without stealing their thunder. So please come back later in the week where you can hear a bit more about GMCSF. But we've got some really nice evidence building that transfer media that contains GMCSF, particularly after warming post-vitrification, has some significant benefits for outcomes. So you can see here that they've seen improved pregnancy rates, improved ongoing pregnancy rates, and improved live birth rates. So this is really exciting. More work needs to be done, but this is something that's been adopted in several countries now, and we're seeing really very good results. As I mentioned, later in the week, we've got an expert panel who'll discuss this and give much more information. So things are being changed, innovations are coming. Ultimately, as I say, The choice of transfer media is yours, but maintaining optimal conditions is crucial. Okay, so I'm just going to go back to the slide showing loading. So we're going to move to the practical side now, and I'm going to ask Anton in a second to load the embryo transfer catheter. We're going to load it with a full column of medium. And then we're going to introduce air bubbles between the drop that has the embryos in. Now, why do I think that flushing the catheter is important and having a full column of media? Embryo transfer catheters of all sorts come in packaging. And it's very tempting for embryologists to pre-warm their catheters, thinking it will help. So they put them in an oven or an incubator, and we believe, okay, we're doing a good service to our embryos and to the transfer. Please do not pre-warm embryo transfer catheters. The packaging was not designed to be warmed up. Around the edges where the two sides of the pack are introduced, there's glue here. And if you warm that up in your lab, you're very likely to introduce VOCs into the lab itself. Okay? Also, it has no real practical benefit, because once you've heated this up, you take it to your workstation, you open the packaging, all the temperature that you put in is lost. So you're introducing a risk for no benefit. Okay? So the way that we warm the catheter, the way that we remove any dry spots, any risk that the bubbles will fragment or embryos will stick, is by flushing the catheter first. Okay? So at that point, once we've discussed the witnessing, Anton will just show you one way of loading the transfer catheter according to these diagrams here. As I say, not the only way, it's only one way to do it. Now, embryo transfer, along with all of the processes getting to embryo transfer, it's critical that we have traceability, we have chain of custody, and we know that when we come to do the embryo transfer, we have the right patient and the right embryo. All of us are aware in the field that mistakes have happened, and we need to do everything that we can to mitigate those mistakes. And witnessing is a key factor. We can do double manual witnessing. It has its limitations, but we can also use electronic witnessing, and that will help us maintain chain of custody, give reassurance to the patients, to the clinicians, to the embryologists, nurses, and we can sleep well at night. Okay? That witnessing system gives us the ability to know that everything went as it should. I'm just going to pass over to Joaquin briefly, and he's going to demonstrate just how we set the system up with a little bit of new innovation that we brought in this year. So Joaquin will just explain the witnessing process to you, and then we'll load the catheter. Once we've loaded the catheter, I'll demonstrate how the simulator that we have works in helping to train on embryo transfer. Okay, Joaquin?
Thank you, Steve. As Steve mentioned, we understand that witnessing of the sample is extremely important. That's why we're very happy to have here our own electronic witnessing system, RA Witness, which is the gold standard in electronic witnessing with over 700 installations globally. So we also understand that sample identification starts with a very strong patient identification. That's why we are very happy to introduce a new feature that is our digital patient ID. So till now, we have been using patient ID cards, wristbands, biometrics like fingerprinting, but now we have an electronic way for patients to be fully ID at any point on the process. So for a transfer like now, what will happen is the embryologist will walk into the room to ID the patient, and they will be able to scan this. So what I just did is scan this ID from the patient, and my transfer station is now locked in place to this patient. So when I go to the incubator to grab the dish and bring it out for a transfer, it will be IDing and making sure it matches with the process.
Okay, so the key point there that Joaquin highlighted is, once this station has been locked, we cannot do anything else here than what we've designated we're going to do. And in this case, it's an embryo transfer. So when Anton brings the dish into the work area, the system automatically recognizes that dish with the right patient's embryos, and he has to confirm on the screen that he's doing an embryo transfer on that patient with that dish. So it's eliminating the chance that somebody else could come in and start doing something else when you're working, and we're only going to be able to do an embryo transfer for this particular patient. So we advise that embryologists wear sterile gloves. These need to be non-toxic, they need to be tested so that they're not going to cause any issues. And we've preloaded the dish, so we've warmed up the dish with our embryo for transfer. We've done some testing previously, maybe pH testing, temperature mapping, so that we know the time we equilibrated the dish is going to leave it in an optimal condition as we come to take the embryo up into the embryo transfer catheter. So Anton's going to flush the catheter through with medium. This, as I mentioned, is going to warm it. It's going to lubricate it. So when you flush the catheter, the media that you use should contain protein, because protein is the substance that's going to coat the inner factors in embryo transfer, is the time that it takes to get the embryo from the incubator into the catheter to the clinician, embryo from the incubator into the catheter to the clinician or nurse who's doing the transfer and getting it into the uterine cavity. So this is all the first part. The second part is the transfer itself. So once Anton's loaded the catheter, it's going to pass it over to whoever's doing the embryo transfer to get, hopefully, a very smooth atraumatic transfer, get the embryo into the cavity as quickly as possible. Now, we have two ways of doing that. We can do a single step or a preload embryo transfer. So if we know the transfer is going to be easy, the patient's had previous transfers that are easy, then we can do a single step or a preload. If we don't know, or there's been some difficulty in the past, we do an afterload technique. So that would be where whoever's doing the transfer gets the outer sheath and an obturator into place first. As soon as they know they're in the right position, call to the embryologist, I'm ready. They would then load the catheter and bring it through, but this time, instead of bringing the whole catheter, they'd just bring the inner part, and we would feed that through. So we train embryologists, we do mock loading, we get them to do these things so they practice time and time again, so they're very skilled and quick at doing it. We also need to train the people who are doing embryo transfer. So we know there is operator variability. If you have a clinic with 20 clinicians doing embryo transfer, they don't all have the same success rates. We have to measure on standard patients, so we don't measure the whole population. When we're doing KPIs, we pick a single population, good prognosis patients, and we measure the data based on those patients. That then gives us a level playing field. So it could say, if Anton and I are clinicians doing embryo transfer, I pick the same patient group, and Anton has a 50% pregnancy rate, I have a 30% pregnancy rate. Now, what does that tell me? I've ruled out patient variability. Says I probably need a little bit of help to be as good as Anton at doing embryo transfer. So we know practitioner variability is a true thing, and so training in embryo transfer is extremely important. But what we don't want to do while you're learning is just use a patient as our guinea pig, because they're totally invested in the outcome. And when you're learning, you're not going to be as good as you are when you've done 200 embryo transfers. So thankfully nowadays we have something that can help us, and that's a simulator that can help us work through a number of transfers, a number of different anatomies, so that we've got some skill base before we move to doing patient work. We always recommend they start doing IUIs first, but when they come to do embryo transfer, there's no going back. As an embryologist, you know, we strive really hard to produce the best quality embryos that we can. The whole cycle, make or break on embryo transfer. If we don't get this right, doesn't matter how good the embryo is, we're not going to succeed. So I'm just going to demonstrate one way of doing the embryo transfer on the simulator so I can show you how it works. And then after that, if anybody wants to come, have a try, talk about different loading techniques, then please come forward and we'll happily demonstrate it to you. So once Anton is finished loading, he would come through to the operating room, hand me the catheter, and I'll do the embryo transfer. And I'm hoping it goes smoothly. Fingers crossed. Okay, so on the simulator, we have one anatomy in here. Now, this patient is perfect. She's got a perfect anatomy. We know that she's going to be easy, or at least should be easy. And if I can't do an easy embryo transfer on here, I'm not going to be able to do it on some of the more difficult, perhaps curved cervix, or a retroverted uterus, or a transfer after a cesarean section. If I can't do it here, I can't move on to the more complex cases. So the simulator gives us some options of things that we can do. We've set it to have automatic ultrasound, okay? But I can, if I'm teaching somebody else to do ultrasound to help me, we can actually use the scanner to do an ultrasound, okay? So in the first instance, that's usually quite difficult. And so we set it on automatic. It makes life easier for everybody when you're learning. The second thing is, if you're not used to ultrasound scanning, or we're teaching an embryologist how to do embryo transfer as an example, they look at the screen here, and it's like seeing a grey cat in a fog. What does it mean? It's really difficult unless you're experienced at ultrasound to interpret the picture. So the system kindly helps us by giving a rendered image of the cervix and the uterus. And what happens when you're training, when you have this section here on, is nobody looks at the ultrasound. They only look at the rendering of the anatomy because it's easy. Our eyes are drawn to the easy part. So the first few transfers we do with this anatomy on, we look where the target zone is for depositing the embryo. That, in this instance, is set by the ASRM, 1 to 1.5 centimeters from the fundus, and at least 1 centimeter away from the cervix, somewhere mid-cavity. So that's our target zone in green. You can see, hopefully you can see it up there. So what I'm going to do, because I'm looking at the image on the right, the first 2 or 3 times I do it, I aim for that green area, but I need to train my eyes to go to the left to see where that point is on the ultrasound. Okay? So I've done that 2 or 3 times. I know it can work easily. Then I'm going to turn this off. So I'm going to turn the outside view off. Now, when I do the transfer, hopefully I've learned from the first view that I've done. Now I have to do it just looking at the ultrasound picture. Ultimately, then I'm going to turn off the automatic scanning, and I'm going to have somebody to help me to do that. So we work through this process with a very simple anatomy, and then we build it up to the more and more difficult cases that fit into this model. If at any time you want to refresh your memory of what the anatomy looks like, we can press the button here, and it shows us what has been recorded previously. So in this case, very straight cervix, straight uterus, it should be straightforward. Set it up as a 1-step transfer this time, because I know it's going to be easy, but we could set it up as a 2-stage transfer. Okay, so we're ready to go. Based on the ASRM guidelines, there are a number of steps we need to follow. And you can either have them on so the person has to follow them manually, or for the case of demonstration to you, I've just switched them off. But I have to follow them, otherwise the system won't record my endeavors. So, thank you. So we've got the catheter in place. Depending on the type of catheter that you use, you can either do the transfer moving straight forward, or you might have to move the inner catheter back to give you a bit more support. So I'm going to do it that way first. I'm going to find the cervix. Yeah, oh yeah. Okay, so you can see now it's on the screen. I'm in the cervical canal. I'm aiming for the internal os, and you can see the picture on the scan on the right. So I've moved the outer sheath too far, so I need to move it back a little bit. Then I can advance the inner catheter forward till I get to where I want to be in the target zone. Press the plunger to expel the embryo. Withdraw the catheter. Thank you. And now we have to check for retained embryos. We're not really checking, but it's telling us that we always need to do that. Once we press that, the simulator does the calculation, and it's going to give me a score and see how well I did. So it will record what you do every time. So here, unremarkably, I got a perfect score. And if all patients were like this, we'd have no trouble. If I want to look in more detail, I can press here. It shows me what it's measuring and how well I did. And one of the key factors is right at the bottom. It measures the speed that you press the plunger. It's something that's really hard to teach people to describe in words how to do a physical process. So the system measures that, and it gives us feedback. And again, if you push too fast, you can expel the embryo too far. If you go too hesitantly, the embryo will stay very close to the end of the catheter, and if there's mucus remaining, there's a potential for it to stick. Okay? So that will measure something that's very hard to describe, as I say. The system is set up, so when I log in, it records everything that I do. So it's recorded this one. When I do it another time, it will record. It gives me all that data. It also gives me the opportunity to look back and record what I did and how I did it. So I can play back. On a simple transfer, it's not so important. But where the cervix is convoluted or you've got a false passage, something like that, I can use the recording to see what I did and see where eventually when I got in, how I did it. Ultrasound doesn't replace the feel when you're doing the transfer. It's a combination. So when you feel an obstruction or a blockage in the cervix, we still need to use feel to get past it, but the ultrasound helps us. So when they say there's clinical touch or clinical feel and ultrasound, they're not mutually exclusive. They work hand in hand. Because when you feel an obstruction, you don't just push the catheter harder, you have to manipulate it to navigate the canal. So hopefully we've got a great quality embryo. We've loaded the catheter with the optimal embryo transfer medium. That's done quickly, brought it through to the operating room. The person doing the transfer does an easy transfer like that. We've got the best chance of the pregnant achieving her goals. If any of those things don't work effectively or optimally, then the chances of success are going to diminish. Okay? So, thank you for listening. We're going to have the demo here. We have a unit here and a one inside the stand. If you want to come and have a go at embryo transfer, if you want to talk about loading, either now or later, please feel free to come back. And really thank you for standing here in the heat and listening. Thank you so much. Yeah, of course.
Turn my microphone off, sorry.
Oh, yeah. Yes.
Cases of cervical stenosis, previous loop, diaphragm, or something like that. If there's any evidence that cervical dilatation